Our today's topic is primary open-angle glaucoma part 2. Many different abnormalities have been noted on histopathological examination of the drainage angle in patients with POAG. These include narrowed intertrabecular spaces, thickened basement membranes, fused trabecular beams, reduction in trabecular endothelial cells, reduction in actin filaments, narrowing of collector channels, foreign material accumulation, scleral spur thickening, and closure of Schlemm's canal. A commonly held view is that glaucoma is a group of conditions with varying pathophysiological processes that share a common endpoint of optic nerve head damage. There are multiple proposed mechanisms of damage, some of which are IOP-dependent, and others are IOP-independent. As discussed above, raised IOP is thought to damage the optic nerve head via induced mechanical changes at the lamina cribrosa, or via vascular dysfunction and resultant ischemia. There are several postulated mechanisms as to the cause of elevated IOP, the majority of which are related to reduced aqueous outflow. Structural changes include trabecular meshwork obstruction by foreign material, e.g. glycosaminoglycans, pigment, red blood cells. Trabecular endothelial cell loss resulting in trabecular beams fusing. Loss of trabecular endothelial cell phagocytic activity. Loss of giant vacuoles from Schlemm's canal endothelium. Reduced pore size and density in the wall of Schlemm's canal. It has been suggested that these changes may be brought on by altered endogenous corticosteroid metabolism, with secondary trabecular meshwork changes, or oxidative damage. IOP-independent mechanisms of damage include reduced ocular perfusion pressure and hence the association with vascular diseases such as diabetes, hypertension and migraine. Excitotoxic damage from excessive glutamate. Autoimmune-mediated nerve damage. Loss of neurotrophic factors. Failure of cellular repair mechanisms. Abnormal autoregulation of retinal and choroidal vasculature. Visual loss from glaucoma is irreversible, and therefore prevention is a key strategy to preventing morbidity from this condition. It is recommended that people over 40 years of age should receive a baseline examination. The patient's underlying characteristics and risk factors determine the frequency of follow-up visits.
Primary prevention of POAG has been shown to occur in the setting of OHT patients.
These patients have elevated IOP but no structural or functional evidence of optic nerve damage. Data from OHTS and EGPS have shown that the risk of developing POAG in OHT patients can be reduced by using topical therapy to lower IOP. Please see the table below on evidence-based guidelines in terms of risk factors. Not enough is currently known about the lifestyle or nutritional epidemiology of glaucoma to inform the public of any health strategies for the prevention of glaucoma. Additional research is required in this area. Diagnosis of POAG requires assessment of intraocular pressure, open normal appearing anterior chamber angle, characteristic signs of optic disc damage, visual function loss on perimetry. Frequently, the diagnosis is not clear-cut and the patient may present with some risk factors and signs, but not others. In such cases, the patient may be labeled as a glaucoma suspect. These patients require repeat assessments at regular intervals with the frequency of visits dependent upon index of suspicion. The majority of patients with POAG are asymptomatic. Typically, patients are only symptomatic in late disease, when they may become aware of constricted visual field or blurred vision. Occasionally, patients become aware of earlier visual field defects when performing monocular tasks, such as using the viewfinder of a camera. More frequently, patients are usually diagnosed as part of a routine eye test or as an incidental finding when presenting with another ophthalmic condition, e.g. diabetic retinopathy. A detailed general history would reveal any causes of secondary glaucomas and therefore refuting POAG, such as steroid usage. Physical examination consists of assessment of IOP, anterior chamber angle, optic disc and visual field. 1. IOP. The gold standard for IOP measurement is Goldmann applanation tonometry (GAT). This is not available in all instances, and non-contact tonometry is also frequently used. In the UK, this is certainly true in the community where optometrists' preferred method of IOP measurement is non-contact. Almost standard now, in conjunction with tonometry, is the measurement of central corneal thickness circuit. Theoretically, a thinner cornea may lead to measurements that underestimate true IOP and vice versa. However, the effect of circuit on IOP measurement is not predictable, and there is no consensus as to the degree of under- or overestimation of IOP that occurs with thinner or thicker corneas. Moreover, circuit is only one biomechanical attribute of a cornea. For example, a thin cornea that is very stiff may still result in overestimation of IOP. Newer methods of IOP measurement aim to overcome variations in corneal biomechanics and give a more accurate estimate of true IOP. These include the Reichert Ocular Response Analyzer (ORA) and the Pascal Dynamic Contour Tonometer (DCT). The ORA is a non-contact tonometer that measures a biomechanical attribute of the cornea termed hysteresis. The DCT uses principle of contour matching instead of applanation to reduce the effect of corneal biomechanics. For more information on tonometry, please see the section Intraocular Pressure and Tonometry. 2. Anterior chamber angle. The anterior chamber angle is assessed clinically using the slit lamp, Van Herrick technique, and with gonioscopy. Newer techniques for angle assessment include UBM, ultrasound biomicroscopy, and as October, anterior segment optical coherence tomography. 3. Optic disc. Clinical examination of the optic disc is a very important part of the assessment of patients with POAG. Direct ophthalmoscopy offers the most magnified view of the optic disc, but the view is not stereoscopic. Slit lamp biomicroscopy with a lens that offers large magnification, e.g. 60 diopter or super 66, has the advantage of giving a stereoscopic view. Stereoscopic disc photographs offer a useful documentation of optic disc status, and also allow masked assessment in trials. Clinical assessment of an optic disc is still considered the gold standard in the diagnosis of POAG, though the inter-observer agreement is notoriously variable. Therefore, there is a drive for more objective optic disc assessment such as Heidelberg retinal tomography (HRT) and ocular coherence tomography (October). Assessment of the nerve fiber layer surrounding the disc by the GDX is also useful. Automated static threshold perimetry, e.g. Humphrey field analysis, is the gold standard for diagnosis and monitoring of POAG. Various testing algorithms have been validated for POAG and allow reduced testing time for patients, e.g. Swedish Interactive Threshold Algorithm, (SITA). Patients with early POAG may have normal visual fields on testing, and it has been estimated that 50% of ganglion cells need to be lost before a field defect becomes apparent. This rationale has led to development of new parametric tests such as short wavelength automated perimetry (SWAP) and frequency doubling technology (FDT), which may be able to enhance earlier detection of functional loss by targeting a specific subset of ganglion cells that have sparse distribution.